Hope everybody has had their snacks. I'm so excited to be here. I should have labeled my talk more of like hope, just because I'm just really excited where the field's going. So once again, my name is Sarah, and these are my objectives. I hope to introduce SBRT in the treatment of lung cancer, talk about common standards of care in the approaches of metastatic non-small cell with brain metastasis, and then I'll also identify malignancy versus disease recurrence, some post-treatment changes seen on imaging for patients with lung cancer. So I first want to test your knowledge and kind of get you thinking. This is a 65-year-old patient with adenocarcinoma of the right upper lobe, a T4N0M0 stage 3A, who underwent concurrent chemotherapy and radiation, and then went on to have a right thoracotomy, which actually turned out to be a pneumonectomy for definitive therapy. And he presents to your clinic with a PET avid left upper lobe nodule, highly suspicious for either a new primary versus oligoprogressive disease. So of your options, think about if you want to monitor your patient, consult thoracic surgery for consideration of resection, consult us in radiation oncology for SBRT or SABR, or discuss systemic therapy, either with chemotherapy or immunotherapy. So what is oligometastasis? Well, it refers to a situation where distant metastasis may be limited in number, typically defined as less or equal to 5 areas or less or equal to 3 organs, and we can potentially offer curative treatment to prevent widespread disease. Oligo comes from the Greek word oligos, meaning little, small, or few. And at least 50% of patients with non-small cell will present with advanced stage 4 disease. And it's also important to know that a significant amount of even early stage 1 to stage 3 will develop metastasis after their initial definitive therapy. So this picture I like because it shows the localized disease, an example of oligometastatic disease, and how that transitions to widely metastatic. Historically, these treatments weren't curative, but now we are seeing that we're more open to the concept based on the limited burden of disease that patients present with. So where did SBRT and SABR? SABR is also defined as stereotactic ablative radiotherapy. That's another term that institutions use. Well, it's a limited burden of metastasis based on the number, location, volume, and symptoms. And as I mentioned, it's potentially curable. How we do it, what are the indications? Well, we like to get a PET diagnosis or biopsy proven lung cancer. We use high dose per fraction. We're able to fit very small target volumes. And we can usually deliver this in as little as 1 to 5 treatments every other day for 1 to 2 weeks. So this is a super short course when we reflect on longer courses with conventional radiation. The challenge is lungs are always in motion, so that's why we work very hard to have our targets tight, and we look at safety parameters as well. And this is just an example of how we map out and contour a tumor. This is what a simulation looks like. So prior to a patient starting radiation, this is how we map out a tumor. The different colors represent the volumes and how we account for any movement as the patient braids. This is how we target the tumor. The 2 rules of radiation is do no harm and do not miss. So the GTV is the gross tumor that you see on imaging. The CTV is the target volume, which accounts for any tiny or microscopic disease around the tumor. And the PTV is our planning target volume, which accounts for any movement. So how would a patient typically present to our department? Well, we see them on surveillance imaging alongside our medical oncology colleagues. We typically see them have 1 to 2 areas of isolated progression. The goal is to maintain them on their immunotherapy and target therapies in the setting of good overall control and tolerance of that therapy. We want to avoid them having to move on to 2nd or 3rd line therapy to get as much mileage out of that drug. And we want to offer local therapy and give them good, durable control. So why do we use this in patients with oligomets? Well, there's a lot of data out there, and studies have reported that there's greater tumor antigen release, antigen presentation, and T-cell infiltration following radiation. So we make the therapies better. These are just the top 10 reasons why we use SBRT in oligomets. There's been a lot of different trials that indicate a benefit with these ablative therapies. There's a lot of supporting evidence that have been evolving. It can be curative, as I mentioned. It's very well tolerated, extremely cost effective when you compare it to standard of care or even sometimes surgery. We want to treat as many lesions as possible, and there hasn't been an exact cutoff of how much do we treat. So this is just a trial that UT Southwestern did. It's a randomized phase 2 trial that looked at stage 4 non-small cell lung cancer patients with less or equal to 3 METs, no progression at the 3-month point after frontline therapy. And they were randomized to either maintenance therapy or observation with local control therapy to all disease sites. And what we see here is an overall progression-free survival from 4 to 14 months and an overall survival from 17 to 41 months by offering that local therapy. Another trial, the SABRE COMET, was also a randomized phase 2 trial that looked at a variety of oligomet patients. And what we see is a progression-free survival increase from 6 to 12 months and an overall survival from 28 to 41 months. We also saw that there wasn't a difference in the quality of life in this trial as well. So patients tolerated it well and had good outcomes. So what are the limits? Well, how many is too many? We don't know, but to date, we typically include 1 to 5 tumors. The SABRE COMET 10 was a trial in Canada and Europe, which is actively accruing, and it allows up to 10 lesions to be treated with SBRT, provided that their disease is otherwise controlled. SABRE doses are anywhere from 20 and 1, which is 1 treatment, to 30 and 3, or 35 and 5. And those doses are basically decided to avoid toxicity and make sure it's safe. And the Canadian phase 1 trial, which is the ARREST, has no max on how many we can treat. So these trials are ongoing, looking at how many is too many, or should there be a cutoff. So how safe is SBRT when we're talking about patients who are on targeted therapies? And since there are so many that exist and the list keeps on growing, a few of them, which are EGFRs, our ALKs, our BRAF, and our ROS1s, appear to be safe when given concurrently with this type of treatment. The goal, as I mentioned, is to get as much mileage out of this targeted therapy before making a systemic therapy change. So looking at the data, combining SBRT and targeted therapy, the phase 3 CINDUS trial was a randomized trial of first-line patients with a TKI with an EGFR mutated non-small cell lung cancer. This trial actually closed early at 68% because there was so much benefit with the SBRT arm. This trial out of University of Colorado looked at progression-free survival with targeted therapy. And these patients that were on targeted therapy who had developed up to 5 different areas of oligoprogressive disease, what they saw was that patients who had SBRT had a median 9-month extension of that therapy before a change was needed. So how do we look at SBRT in patients with immunotherapy? Well, once again, it's safe, and what we know is that it alters the tumor's microenvironment to potentiate effects of the immunotherapy. So they work together to improve the results of the treatment. Looking at trials that looked at pembrolizumab, for example, with SBRT, this was a trial out of Mayo that was a single-arm trial of 51 patients with oligometastatic non-small cell. They had less or equal to 4 metastatic sites. We gave local ablative therapy to all known sites of disease, and what we found was a 78% survival at 2 years. Pembro, after the local ablative therapy, yielded no safety concerns, so it was well tolerated, and there was not a reduction in their quality of life. This trial also looked at Pembro as a phase 2 with 92 stage 4 non-small cell lung cancers. And it added SBRT to 1 lesion prior to the administer of Pembro. And what it looked at was an improvement in the local control rate. We had a median survival advantage, and there was no added toxicities. This is another trial, sorry for all the data, but this Pembro study looked at 148 patients with at least 1 lesion treated with SBRT. And what we see here once again is an improvement in progression-free survival as well as overall survival. Nivolumab, this trial was specifically looking at the safety and how safe it was to administer SBRT in the setting of nivolumab, and they found that there was no grade 3 toxicities, and there was a 4-year event-free survival when adding nivolumab with SBRT. So what happens after we give SBRT? Well, I want to talk to you about what we see on imaging. Radiation pneumonitis is probably one of the more common things that we see, and it involves the lung tissues, and it appears in a linear or high dense consolidation. Often this indensity resembles primary lung cancer, so it's really important that you follow these and work closely with your radiologist because it can be quite tricky to differentiate between what's normal post-treatment changes and what could be early recurrence. So this picture just kind of shows you post-treatment and up to the 5-year mark, what a typical change can look like after we treat a tumor. Radiation pneumonitis can start as a dry cough. It's important to know that this occurs as early as the 6-week mark up to the 6-month mark after post-treatment. So if someone has a cough like a week after treatment, it's most likely not in the setting of pneumonitis. It's typically grade 1 or 2, most often grade 1, where you see it on x-ray, but a patient doesn't necessarily have a symptom. We treat this with a course of steroids, usually Decadron, anywhere from 2 to 6 weeks, and then we taper it according to the patient's symptoms. Fibrosis or scarring of the lung can develop as well. Generally, patients don't have symptoms. We expect minimal changes in their PFTs, but depending on their overall lung function, and if they have a poor baseline lung function, the fibrosis can get quite severe and impact patients' oxygen demand, and that sort of thing. So these pictures are an example of pneumonitis that we see. Picture A is a grade 1. So that would just be something you see on imaging, but the patient doesn't feel it. Picture B is a grade 2. They may need a little help with some Decadron. Picture C is your grade 3s. This often patients may need some oxygen at this point. And the picture D is a grade 4 or 5, and these patients are intubated in the hospital. This is very, very rare. So now I'm going to go through what we expect to see after SBRT. And this is, if there's any takeaway or pay attention points, this will really help you in practice and also help your radiologist. So this is looking at very normal changes that we see after SBRT. And this is a diffuse consolidation. So as you can see in our planning CT and then 4 months after treatment, we can see that consolidation. This is patchy consolidation at the 4-month mark, very typical normal changes. Then we go into the diffuse ground glass opacities, which is probably most often what we see, changes in the 0 to 6-month range. And this is our modified conventional pattern of fibrosis. So this is very typical findings that we would expect to see. This is scar-like fibrosis, and you'll see terms like this in the findings of your imaging. The most important piece of this is that we see a linear opacity. So it's a straight line in the scar. This can be best seen usually on the sagittal views when you're looking at your CTs, but we want to see the linear after treatment. Mass-like fibrosis probably is the most problematic because it often resembles what a tumor can look like. And the most important thing about this is the density and consolidation is in the main part of what was treated. So you'd want to consult us or your radiation team and say, you know, what was your radiation field? And is the consolidation or fibrosis that I'm seeing, is that in the heart of what you treated? So this is where we would refer to our treatment plans and kind of watch this very carefully. So some concerning findings, these are your main ones. So you want to be looking for an enlarging opacity, sequential enlargement, cranial-caudal growth, a bulging margin, loss of linear margin, so loss of that line, and loss of an air bronchogram. So these are your high-risk radiographic features, and this is what you're going to want to talk to your radiologist about. And this is an enlarging opacity or increased density within the area that was treated. And this is a little bit further out from treatment. This is sequential enlargement. So as you can see from the point of treatment, it's getting larger on serial imaging. This is your craniocaudal growth, and that's usually measured at greater than 5 millimeters or 20%. As you can see, that linear aspect, there's growth up and down in that craniocaudal directions. We expect to see some growth in the axial planes, but once we see growth in this, it's most often not radiation related, and you're going to want to either consult your interventional pulmonology team for a biopsy and get a PET scan. So how do patients tolerate it? Well, we usually say it's very well tolerated, and this trial specifically looked at multiple prospective trials in evaluating how safe it was. And what they found was most studies showed a less than 10% grade 3 toxicities, but a significant clinical benefit. Some of the key points: SBRT offers excellent local control with minimum toxicities. We can slow the progression and delay systemic therapy treatment transitions. It's very patient-friendly with a high favorable quality of life. It's cost-effective when compared to standard of cares or resections. Technology is only improved, and then the utilization is consistently expanding. And trial enrollment is key for us to even get better at what we're doing. So now we're going to kind of shift gears and talk about the role of SRS, which is stereotactic radiosurgery, in the setting of brain metastasis. So treatment of brain metastasis, there's multiple options, and it really just depends on how your patient presents. Approximately 20 to 40% of cancer patients will develop a brain metastasis within their diagnosis. Lung cancer, when you compare it to breast cancer and even melanoma, as you can see, has one of the highest probabilities of developing a brain cancer. And the areas that we see most of brain cancer develop is in the cerebral hemispheres at 80%, the cerebellum, and the brainstem. And stereotactic radiosurgery is becoming very popular because it's we can treat up to 10 lesions, and we can give really good control, and we decrease a lot of toxicities when comparing it to whole brain radiotherapy. We do have a technique where we can offer what's called hippocampal sparing, where we spare the hippocampus, which is the memory center. This offers a reduction in cognitive deficits and memory changes, so it's a little bit more well tolerated. We can only offer that if there's no cancer involvement in that area. We can offer standard whole brain, which is given over 2 weeks. It's very toxic, but it's usually indicated if patients have more than 15 lesions. We can also do no radiation, and that's where we're going to talk about new advancements in systemic therapies. Common presentations, as you all have probably seen in your practice, headache being up there as a high percent, some mental changes, cognitive deficits, weakness. So these are some things you want to kind of keep on your radar if you have a patient that's at risk for developing a brain metastasis to look for. So if your patient comes to you with a symptomatic brain metastasis, usually our approach is to consult our neurosurgery colleagues to see if they're a candidate for surgical resection. This will offer the quickest way for them to get relief of their symptoms. Radiation takes time. So if they're very symptomatic, we need to get them to see if we can get it removed and offer them some relief. We will give Decadron up front. Typically in our institution, we give a 10 milligram dose times 1, and then we figure out a pattern, 4 milligrams Q6 versus 8 milligrams twice a day. And we want to consider some seizure prophylaxis, especially if you have a metastasis in the temporal location. SRS is a really good option to treat someone with a symptomatic brain metastasis, especially if they're not a candidate for resection. We want to get them in, get them on Decadron, and then we actually taper that Decadron over 1 to 2 weeks following our treatment to make sure that we account for any swelling and side effects. We perform an MRI at approximately 2 months after the stereotactic radiosurgery to see a treatment response. Patients with greater than 10 to 15 metastasis, we're now looking at offering them whole brain at that point. And typically our setup is 30 gray and 10 fractions, so that's given over 2 weeks. In some situations, we will do a shorter course depending on the patient's performance status and a desire to get them on systemic therapy quicker. And a patient with asymptomatic brain metastasis, surveillance is actually becoming a popular option with MRI every 3 months. And those are for patients with very small or punctate areas that are not causing them symptoms. Typically, that size is between 3 and 5 millimeters. If a patient is on a targeted therapy or immunotherapy with good CNS penetration, we also favor monitoring them because they may not even need to have radiation. For patients with brain metastasis greater than 6 millimeters with some swelling, we want to start talking to them about treating them with SRS. For patients, and we also can offer it to them with 10 to 15 metastases just to avoid them having to need whole brain radiation. Critical locations like the brainstem, for example, we have a lower threshold to treat just because if it grows even the slightest bit, they're going to have major symptoms. So this is a great slide, which helps us kind of take into consideration before offering them treatment. And these are just a list of the several drugs that have really good CNS penetration. So if you're working with your medical oncology friends and they have a patient on this, it's really good to know these drugs before offering them treatment. Osimertinib, for example, on the Bloom trial had a 58% CNS penetration. Some of the good ones with the ALKs is your lorlatinib. And then, of course, the others that I have highlighted there have really good CNS response. So what is stereotactic radiosurgery? Well, much like SBRT in the lung, small volumes are target. So we're able to target very small areas and limiting toxicity to the larger brain tissue. Larger doses are given over a few fractions. Usually we can give it in as little as 1 fraction. Target ablation is of course the goal. It was originally intended for neurologic disorders, but it was then found to be very effective in treating brain cancer. So this is an example of an SRS plan. So you can see how tight those fields are and how we're sparing a lot of the healthy brain tissue. And some considerations is usually our treatments are between 1 and 5 fractions, depending on the size, where it's located, and if they're post-op. If they do go for a craniotomy or a tumor resection, we do what's called fractionated SRS, where it's given over 3 to 5 fractions to the post-op cavity. We usually do this about 1 month after resection to allow for healing. And one thing that is required is a thin sliced MRI. It's usually 1 millimeter for us to look at the post-op cavity to check for any residual disease and make sure that we can target the correct area. It's safely performed even with patients on targeted therapy and immunotherapy. Sometimes we do make dose adjustments just to avoid added toxicity, so we wouldn't have them get their immunotherapy on the same day as their SRS. We have also shown that SRS can be very effective even with aggressive trials. So the FIRE small cell lung cancer trial looked at the median overall survival, increasing to 8.5 months when compared to whole brain. So even with really aggressive cancers, SRS is becoming the favored treatment. It can be safe and effective for even multiple brain mets. So the 2022 ASTRO abstract was a phase 3 randomized trial comparing SRS versus whole brain for patients with 4 to 15 mets. And the overall survival was 8 months compared to 8.9. So the overall survival was comparable. However, there was improved cognitive scores in the SRS arm. So we were able to avoid that toxicity while still giving them really good control, even for multiple brain mets. Once again, trying to avoid doing whole brain. So what are some of the side effects? It's usually dependent on where the tumor is located in the brain. Fatigue being the most common, we can expect that to last about 2 to 4 weeks. They can have mild headaches, feel a little nauseous, have some gait imbalances. Hair loss is minimal, much like this picture, probably even less than that. They can develop seizures from the swelling. That's very rare. And they can have vasogenic edema and radiation necrosis, seen in about 10% of patients that are treated. We do not typically see skin irritation or breakdown, and we do not see memory loss with SRS. Management of these side effects for the edema, we do the Decadron, much like we can do in the lung, 2 to 4 milligrams, usually for a week after treatment, sometimes longer. On rare occasions, they need longer courses of Decadron, and we do consult our neuro-oncology teams to help us manage and consider things like Avastin. So how do we do with SRS and immunotherapy? Well, areas previously treated with this type of radiation can develop what's called pseudoprogression while they're on immunotherapy. And the reason for this is we see an increase or size in the enhancement, which reflects the inflammatory cells unleashed by the immunotherapy to go after the cancer. If it's true pseudoprogression, the size and the enhancement will decrease or stay stable on serial MRI imaging. If it's true progression or in-field failure, we'll see persistent increase or growth over serial imaging, and then patients will actually continue to develop symptoms. So how do we look for this, or how do we determine this? Well, we use MRI perfusions after SRS, and this specifically looks at the cerebral blood flow to the tissue. And we use this to determine, is this infarct, differentiate between different brain tumors, and distinguish between true radiation necrosis or tumor progression. Remember that tumors have their own blood flow. So an area that's with high perfusion or cerebral blood flow, you're going to be concerned that there's cancer there and it's not dead tissue. Here's an example of a patient with a left parietal met. On the right hand, you can see the lesion that was treated, but in the perfusion scan, we don't see any added perfusion there. So that is an example of a treated metastasis with no blood flow. So some key points: it's well tolerated. We can offer very good durable local control. It's safe even with immunotherapy and targeted therapies. We can use MRI perfusion to help guide if we have concerns. Whole brain, even though it's effective for multiple CNS lesions and has very good control, there's significant neurologic toxicity when you compare it to SRS. SRS can preserve a patient's cognitive function without compromising their overall survival. And we know now that SRS can be even effective with aggressive cancer, such as small cell, and we can treat more lesions and it will be safe and effective. So coming back to our question with your 69-year-old who now has a PET avid left upper lobe nodule that is PET avid, and you're not sure if it's a primary cancer or in the setting of oligoprogressive disease, think about which options you would choose. And if I could have a raise a hand for question A, B, C, yay. And then question D. Thank you very much. I hope you learned something. And now I'd like to take.
Sarah, would you biopsy that lesion?
So it depends. We will treat without a biopsy. If something, if it looks like a cancer, walks like a cancer, it's probably a cancer. Biopsy often comes with a lot of risks. So it's a conversation. If it can be biopsied with relatively low risk and we, have them meet with them, biopsy obviously, gives you that tissue confirmation. But in patients with poor lung function, this patient, for example, had a pneumonectomy. And so his lung function was limited to only the left side. So putting him through a biopsy would come at great risk. So we actually decided just to trade off the PET. And I'm happy to report that he is disease-free. And we're 3 years out from doing the SBRT. And that particular patient got 30 gray in one treatment. So only one trip in, we were able to control the disease. So.
What patients are at more risk for a higher grade of radiopharmaceuticals?
So patients who present with kind of baseline bad lung function. So if they sort of have rip-roaring COPD, emphysema, we're already seeing some interstitial changes. Those are your characters that you want to watch a little bit closely. Fortunately, because I showed you those target volumes being so precise, we're not seeing a lot of that. So even in patients with ILD, it used to be like, whoa, like hold your horses. Now we're actually seeing that we can do it quite safely because we're able, our technology's gotten better. We're able to really target and minimize a lot of added toxicity to the healthy lung. I hope that answered your question.
Thank you.
Anyone else?